Good morning. I'm Raghu Kolluri. I'm vascular medicine from Columbus, Ohio. I'm a board member for VIVA. I have two phenomenal interventional radiologists with me, friends and colleagues for a long time now. To my left is Dr. Mark Garcia, endovascular consultants from Delaware, and to the right is Mahmood Razavi, interventional radiology from St. Joe Heart and Vascular in Orange County, California. So, gentlemen, let's talk about the pressing issues in venous disease. The biggest controversy, whenever I talk to my interventional colleagues or phlebology colleagues, the constant question we face is, okay, in sort of severe spectrum of venous disease, do you fix the reflux first or, obstruction first? That's the biggest controversy I hear. Is there anything else you gentlemen might think is more controversial than that in 2018?
Mark?
Well, I think there are several issues that we have to address with venous topics, but concerning deep versus superficial, I probably take a not well liked stand by many of our colleagues in that I look at the entire arterial and venous system as a plumbing system, in the body. And the problem with the venous disease is most of what we see is all related to venous hypertension. And so what is the problem with venous hypertension? And when we look at patients who have reflux, I think it's imperative to make sure they don't have an obstructive lesion that can create that venous hypertension. In my practice, I see a lot of patients that have the combination. And quite frankly, to me, it makes a whole lot more sense to treat the central obstructing lesion first, because this is just anecdotally, 50% of the patients that I see don't ever need to get their
reflux eliminated.
Their reflux treated, yeah. So I think it's always prudent to first fix the major problem, the central problem, and then if something else needs to be done, then address that. So I'm a deep guy first.
Okay. Mahmood, you've heard about the EVRA trial, correct?
Yep.
So that is the most serious, form of venous disease, venous ulcerations, and it's a well-designed, randomized controlled trial, not anecdotal, right? And we have granted the ulcers were small, 3 to 7 centimeters, and they showed significant improvement, more than 90% at 1 year, and less than 10% recurrence, unheard of so far, if you fix the reflux first. I mean, it's this most severe form of venous disease, venous ulcers. And out of the 6,000 patients that were screened, about 190 patients were excluded for obstruction. Rest, they did not even look for obstruction carefully. So what do you think of that? Without even looking for obstruction, they achieved 90%, resolution of venous ulcers.
So
I'm trying to play the devil's advocate here. Yeah.
First of all, the area remains controversial.
Yes.
The fact that central venous occlusion is a culprit or a contributing factor to chronic venous insufficiency is also, you can't argue with that either.
Sure.
It is true that not all reflux patients have central obstruction, and it is true that correcting the reflux, you will probably, more than likely, based on this study, correct enough of a venous hypertension problem for the ulcer to heal. There are a lot of people with central venous obstruction who don't develop ulcers, so the combination of the two, obviously, it's a setup. Yeah. So to Mark's point is that, and as you know, there have been some retrospective single-center data, not small number of patients, that show that if you just fix a central axial obstruction, that ulcers heal. But the fact is that whenever there are two lesions, that you need to address them. Now, in our practice, we go for the superficial reflux first. But they do get screened for central obstruction.
Excellent. Yeah, I mean, it is chronic venous disease. I mean, it should be tailored for each patient, right? And you look for both is probably what the right answer is. Okay, let's move on to the next topic. I mean, it's been, more than a year since a tract has been published. And what do you guys think in your communities? has happened in terms of, referral patterns for advanced deep venous interventions after the ATTRACT trial?
Well, the ATTRACT obviously dealt with acute deep venous thrombosis, and as you're well aware, most patients around the country, around the world with acute deep venous thrombosis just receive anticoagulation. It was a very small number of patients, in a single-digit percentage, that were referred for treatment, catheter-based treatment. So the ATTRACT obviously was a negative study, including both FEMPOP and including a FEMPOP through the iliacs, but the entire study was negative. But the FEMPOPs were particularly notable because no difference whatsoever was seen in the primary endpoint study. Neither did we see any difference in the quality of life assessment of the patients. So in our practice, the number of the consults has not changed, but those that we do treat have changed.
So those the pattern has changed.
The pattern that we treat.
Yes,
the number.
That's what I meant, yeah.
So those who have mild disease and clot isolated to the FEMPOP segments, we usually just anticoagulate and observe them. We follow the ultrasound. If it extends, we treat those. If the symptoms get worse, the usual. However, those with iliofemoral, particularly those with clot in the strategic segment, which is the common femoral vein, we still treat those.
Okay. So, Mark, you are the PI for Access PTS. Now, Mahmood says that there's no difference in interventional management, treatment of femoropopliteal DVT. Tell us about Access PTS, where you are, and how you would respond to that comment.
That study is for acute FEMPOP that he's referring to, that showed no difference between standard of care anticoagulation and compression versus treatment. However, if you look at the study, 44% of the population still goes on. FEMPOP goes on to develop post-thrombotic sequelae and syndrome. So what Access PTS is taking the population that actually fails standard of care and allowing us to evaluate whether or not intervention can be performed and can be successful and can be safely performed. What we've been told for a century is that chronic DVT nothing can be done. You have to learn to live with it, and you get anticoagulation, compression, and ulcer care if you have that. And what we were able to demonstrate in Access PTS was that intervention can be performed, can be safely performed, and we can significantly and statistically improve Villalta, VCSS, and quality of life measures based on it. And if you look at the one-year data on that population that was treated, the Doppler patency rates are phenomenal. They're basically essentially greater than 90%. So it was really an initial launch into basically identifying the opportunity to take the population that fails and do something for them and make quality of life better.
I mean, there's an important point there in that we're now not treating those acute FEMPOP thromboses.
Only to kick the can down?
Only to kick the can down to him. But it would be good to know who fails.
Yes.
So we could treat them upstream so they don't get to that point. But since we don't know, if they get, it's good to know that now we do have a solution to reduce the magnitude of the problem. If I understand correctly, it's not a cure, but it just reduces the magnitude of the problem.
Yeah, although some patients will flat out say that they have been cured of post-thrombotic.
They become asymptomatic.
They become asymptomatic and have incredible quality of life. One last thing I wanted to make comment on the ATTRACT trial. People say it failed. It actually didn't fail, right?
No,
It's given us
a lot of signals.
Information. And most importantly, I think, is that if we look back at stroke, and we've said this before, you look back at the first NIH-sponsored stroke study, it was negative, right, for intervention. And here we are today with stroke centers all across the country. We just need to understand it better, the pathophysiology, the patient population that needs to be treated. And it really has helped tailor our algorithm to say that if somebody presents with acute DVT, they get anticoagulation, compression, tell them to ambulate as much as possible, and we do serial ultrasounds. We allow them to declare themselves who's going to go on to PTS, because I don't see there's a difference between 2 weeks and 4 weeks of treatment. I've never felt that in 20 years of doing DVT. So I still intervene at 4 weeks when they start to declare themselves as not resolving and going forward with PTS.
So, let's talk about a couple of things combined here, okay? Mahmood, you are the best entrepreneur I've known so far.
I take the compliment.
Yes.
Not true.
That I know of. Okay, so tell us about what are the products in pipeline in venous disease, particularly after a tract fallout. The concern is, if you can take care of the clot by minimizing the bleeding risks, then you probably would achieve what you want to achieve without bleeding risk in terms of PTS. So talk about that, and then I want to hear, both of you, talk about your views about the new cuts in CMS that are expected over the next 3 years. What's the point in having all of these technologies, if they're not reimbursed?
So Mark pointed to the comparison of the stroke, ischemic stroke in the brain, and the fact that the first large NIH-sponsored randomized study was negative, and then immediately thereafter, several studies were stopped early, right? And the reason for that is that at the time of the first stroke study, we didn't have the right tools. So the toolbox of treating deep vein thrombosis is also improving. Okay, the thrombectomy devices are improving. Our techniques, removing the clot, how to optimize that, those are all improving. And there is a number of very promising devices that have just entered the market, are being put to good use. And hopefully we would see this similar sort of impact as we saw in a stroke in patients with deep vein thrombosis. The other area that is moving again is the issue of the patients who have had damage to their venous valves, that because of clot or various traumas, that now various non-surgical treatments becoming available as well as surgical treatments to correct this reflux and address the venous hypertension. And of course, now we have a good number of venous-specific stents for the central obstruction that Mark was talking about.
Multiple trials.
There are multiple studies. You have 3 completed, 4th one in the process of being completed. And so we will have multiple good devices for all aspects of deep venous disease.
What about the payments? Let's talk about that. Would be our last point of discussion here.
Yeah. I think that we have a great opportunity. Look, venous disease, by estimates, are 4 to 5 times what arterial disease is. There's a huge population out there that suffers from some degree of venous disease. And I think Mahmood hit it right on, is that, with newer tools, I think we get better results. And as we go forward and do more research and studies, we're going to show the benefit, ultimately, of what we do. I think that there's no doubt 5-10 years from now, this will be a moot point. But getting there is a challenge. We need to have industry continue to put funds into this degree, which we've all seen. I mean, in the last 3 to 5 years, industry is very focused on venous disease. So that's beneficial to us all. It's going to benefit the patients.
Particularly advanced venous disease.
Advanced venous disease, correct. And so we just need to utilize, our societies, get better research, engage industry better, and then ultimately, when we put this package together, we need to sit down in front of the government and CMS and say, hey, look, this is a serious problem. There's a large population, and we can make a difference and improve their quality of life, which is really what it's all about. Yeah. And once we do that, I think we'll see the trend of decreasing reimbursements change and go up. And it's on us. We have to show it, and I think we've done a very poor job up to now showing the benefit of intervention. And lastly, I think what's most important is we have to develop guidelines. And if we don't do guidelines, then people are just going to go out there and try to make a big buck on it. Right? Consensus guidelines that say, if you don't do this, you won't get reimbursed. If you don't see this, you can't get reimbursed. Once we do that, I think we'll be sitting good.
So I completely agree. Also, keep in mind that general medical community and also patients are usually not well informed about the latest and the greatest in treatment of venous disease. Traditionally, we've not had the tools to treat chronic venous disease. And so most of our referring physicians and patients don't even know that there are solutions to some of the problems they have. And it's important to extend that education. Also, same thing to the payers. Let them know that there are cost-effective ways to treat these patients with great societal impact and obviously in a cost-effective fashion.
So I'll end, the interview on the note about the cost effectiveness. It's just not the catheters and the immediate hospitalization, but I think healthcare economics of how you save the healthcare dollars. We talked about how we kick the can down the road, eventually, and then maybe they'll end up having costs related to wound care, Apligraph application, compression therapy and that kind of stuff. That's not insignificant in these patients. But, I'm glad we had this nice chat. Thank you, gentlemen.
Thank you.
Thank you very much.
Thank you for having us.